Okay, we're gonna go ahead and get started. Thank you all for joining. My name is Lindsay Miller. I am a 11-year papillary thyroid cancer survivor, and this is my first time being at the in-person conference. I'm from Albany, New York, so it's great to see you all. It's my pleasure to introduce our two speakers who will be joining us virtually. The first is Dr. Carolyn Nguyen. Dr. Nguyen is an endocrinologist and an assistant professor of clinical medicine in the Division of Endocrinology, Diabetes, and Metabolism, and the Department of Obstetrics and Gynecology at Keck Medical Center of USC in Los Angeles, California. Her clinical and research interests are related to the diagnosis and treatment of thyroid disease, with a special focus on thyroid disorders in pregnancy, including hyperthyroidism, hypothyroidism, subclinical thyroid disease, thyroid cancer, Hashimoto's, and postpartum thyroiditis. Our second presenter is Dr. Desai. Dr. Desai is an endocrinologist and clinical assistant professor of endocrinology at Stanford University in Palo Alto, California. Her clinical practice focuses on the management of patients with thyroid diseases, including thyroid nodules and thyroid cancers, and the management of patients with pituitary disorders. She also maintains board certification in neck ultrasonography and internal medicine. So thank you both for joining us, and I'll turn it over to you. And then when your presentations are done, I'm happy to help facilitate Q&A here in the room.
Great, thank you so much. So I'll go first. I'm Dr. Desai, and I just wanted to thank everyone for being here today. Cancer is a very anxiety-provoking issue at any stage, but being pregnant or becoming pregnant on top of that is a huge concern that can be even more on top of the cancer diagnosis. So today, Dr. Nguyen and I are actually going to be discussing thyroid cancer and pregnancy. For the first part, I'm going to be talking about cancer diagnosis that's diagnosed during pregnancy, and then cancer monitoring after or pregnancy after cancer has been treated. So it's going to be kind of two parts. And then Dr. Nguyen is going to be focusing on fertility treatments, breastfeeding, and just fertility in cancer patients in general. Okay, so we'll start with what happens if you become pregnant and then you find a new cancer diagnosis. We'll talk about the diagnosis and treatment during pregnancy. And then we'll talk about what happens after you've had thyroid cancer, it's treated, and now you want to become pregnant. And I kind of did the formatting in a question answer kind of style. But if people have questions, feel free to interrupt me throughout, or you can save your questions till the end. I'll be happy to answer throughout the way as well. So how common is thyroid cancer during pregnancy? The prevalence of thyroid nodules actually vary between 3 and 20 to 30% in women of childbearing age. And there is growth of the thyroid gland up to 10% in pregnancy. So a lot of stuff grows during pregnancy, the thyroid gland, the pituitary gland, being two of the glands that grow. So this can result in a growth of previous nodules or new nodules occurring in patients. The good news is that most of those nodules are not cancer, so the cancer risk is still 5 to 10%, whether you're pregnant or not pregnant. And so if we're looking at just pregnancy diagnosis that occur, or thyroid cancer that occurs when a woman is pregnant, it's actually 14.4 per 100,000 births. So this increases with age and the number of pregnancies you have, as does thyroid nodules increase with age as well. So that forwards true in the pregnant population as well as in a non-pregnant population. So we actually don't have that many studies currently on this small group of population, but it is expanding. And so there's going to be more studies coming out in the next decade or two regarding pregnancy, thyroid cancer, and fertility in thyroid cancer patients. So what are some of the symptoms that thyroid cancer presents during pregnancy? So the most common thing is that there's an incidental finding of a thyroid nodule in imaging. Ideally, pregnant patients should have little or few imaging, but it does come up from time to time. The other main symptoms are a pretty big neck mass or lump and voice hoarseness because of the growth of the nodule. So any of these are different ways that you can get diagnosed with cancer during pregnancy. And they're very similar to the non-thyroid cancer patients or non-pregnant patients. So how do you diagnose thyroid cancer during pregnancy? Well, we start off with a history and physical exam of the neck. We know that the thyroid gland grows during pregnancy, and this can cause a goiter, which is basically just an enlarged thyroid gland. Most women will actually get a neck exam during their pregnancy. This is often done by the OBGYN, but it can be actually done by any internal medicine physician or urgent care if necessary. Risk factors for thyroid pregnancy are the same as in the general population, which includes a family history of thyroid cancer and radiation during the neck area, especially during childhood. And what we do if we notice the neck mass on physical exam is that we check thyroid function tests at that particular time, at the screening TSH and a free T4 level. For imaging wise, the preferred imaging is the same whether or not you're pregnant, which is ultrasound of the neck, which includes the thyroid gland and any sort of lymph nodes. This is actually safe to do during pregnancy because it's ultrasonography. There's no risk of radiation, and it's of your neck area. There's no risk to the fetus at all. And if nodules are found or if abnormal lymph nodes are found, we use the TI-RADS and ATA criteria for determining whether a fine needle aspiration biopsy is necessary. If your endocrinologist or OBGYN recommends a fine needle aspiration biopsy, that is also safe during pregnancy. It's ultrasound guided and it's an outpatient procedure. There's no risk to you or the particular fetus that would be different if you were not pregnant. And pretty much the same cytology findings are used whether or not you're pregnant, which is the Bethesda criteria that we use, which diagnoses whether a nodule is benign or if it's malignant. Most of the thyroid cancers diagnosed during pregnancy are actually differentiated thyroid cancers. So particularly most common is papillary with about 80 to 85% of them, and follicular with about 10 to 15%. Very rarely you can have medullary thyroid cancer present in pregnancy, and it's very, very, very rare for anaplastic thyroid cancer to present during pregnancy. And complications of the biopsy are the same to non-pregnant patients, which are very rare, but you can have a little bit of bleeding because it is a biopsy. You can have a little bit of bruising, or you can have pain at the biopsy sites. So what do you do after we do the fine needle aspiration biopsy of the thyroid nodule? And this is actually, majority is the same as if you were non-pregnant, which is if it was a benign thyroid nodule, we would follow up with an ultrasound after delivery unless you felt like the mass was growing. But ideally it would be at least 6 weeks after delivery. If it's an atypical finding, so they found cells, but they didn't look normal, but they didn't look like cancer, again, these would be monitored with a follow-up ultrasound after delivery. Most of these nodules are benign on repeat FNA. The issue is that molecular gene testing of ferment thyroxine have not been tested in pregnant patients, so we don't routinely use them, just because we don't know what the genetic testing would have been differently if you were non-pregnant. And then if it's suspicious for thyroid cancer, most of the time we monitor with serial ultrasounds during pregnancy. If you are diagnosed with papillary thyroid cancer, that on FNA biopsy, there's a 99% chance that it is thyroid cancer. And those patients in particular have an option of either surgery or monitoring. But pretty much if we don't find cancer in the biopsy, we're not going to recommend surgery. Everybody else is going to be monitoring either during pregnancy if it's suspicious, or after 6 weeks after pregnancy, if it's atypical, or up to 6 months after pregnancy if it's benign. So what are our treatment options of thyroid cancer during pregnancy? Monitoring, also known as active surveillance. We do this in a majority of patients. This is the preferred route because there are complications to doing surgical treatment during pregnancy. And this is often recommended if the cancer is pretty small. We're going to talk about, any sort of risk factors which would lead us to do more treatment during pregnancy. The other treatment options are surgery. Usually if you have lymph nodes or other reasons, we would do surgery in the second trimester. The third option is thyroid hormone replacement, especially if you were hypothyroid when we check your blood work. Radioactive iodine is actually contraindicated during pregnancy and breastfeeding women, so we do not do this in pregnancy at all. And the reason is that the radioactive iodine actually can have radiation effects on the fetus. And it's actually concentrated, iodine is concentrated in the breast during breastfeeding. So it would increase your risk of breast cancer in the future, as well as we don't want that radiation exposure to go towards the baby in the breast milk. So during pregnancy, we monitor the thyroid cancer with thyroid ultrasound each trimester, and it depends on when you're diagnosed. Most patients will be diagnosed at sometime at the end of their first to early second. We would repeat the ultrasound in the third trimester if you're already in the second trimester. We advise for a slightly suppressive therapy with the TSH goal of 2.3, which is the bottom of most labs, but it could be up to 0.5 depending on what laboratory you go to 2.0. And then thyroid surgery after delivery. Generally, it's recommended to wait 6 weeks post-delivery just to recover from the actual delivery. But you can do it even later depending on what issues that may have arisen during delivery. So there is a small subset of patients that need surgery during pregnancy, and who would that be? So if you have any sort of abnormal lymph nodes, we're a little bit concerned that the thyroid cancer has already spread outside the thyroid gland, your endocrinologist or your obstetrician may recommend surgery. Any sort of aggressive variants of thyroid cancer, these are generally hard to see on FNA. But if there's a concern that the cancer is growing, or if you have a concern that you have a non-classical type of papillary thyroid cancer, some physicians may recommend surgery during pregnancy. If you have distant metastatic disease, very, very, very rarely, if you have medullary or anaplastic thyroid cancer, those need to be treated on a faster time frame than papillary or follicular. And then if you have some sort of enlarging thyroid nodule, so over a 50% growth in volume or 20% increase in 2 dimensions or more in the second trimester, then there's a concern that this is a faster growing cancer, and therefore we would recommend surgery. And what would those risks be? So there are both maternal and fetal risks to consider. The risk of miscarriage is highest in the first 12 weeks, which is why we generally don't recommend surgery before 12 weeks. So surgery is completed sometime in the second trimester. And surgical complications include bleeding and infection, which are non-endocrine related. And the endocrine related ones are maternal hypoparathyroidism, which is a low parathyroid hormone. This can lead to low calcium levels. You can also get injury to the recurrent laryngeal nerve during surgery, which causes voice damage. And to kind of prevent these sort of surgical complications or decrease the risk, and generally pregnant patients are referred to a high volume center where the surgeon does a significant amount of these surgeries, and that lowers the rate of complications. So if you're in the group of patients who already had thyroid cancer before you got pregnant, when is it ideal to get pregnant after being diagnosed with thyroid cancer? So I'm going to shift the focus a little bit. So ideally, we should have all your treatments finished, and you should have no evidence of disease. That will be probably like 80 or 90% of patients. However, if this is not possible, it's to have a complete no evidence of disease, it's kind of important that your disease is stable at the time of pregnancy. And that would be kind of a discussion between you and your endocrinologist about when an ideal time to get pregnant is in that small percentage of people, which is usually less than 10% of people. So if you were to have surgery for your thyroid cancer and only need surgery, like say you were getting a lobectomy, or you opted to get a total thyroidectomy, but you were pretty low risk and were not getting radioactive iodine, then ideally you could get pregnant 3 to 6 months after surgery. The main limiting factor on when to get pregnant is 2 things: is you want to recover from your surgery, and then you want to make sure the TSH is at goal for pregnancy. So for the first trimester, ideally it would be less than 2.5. So depending on how long it takes your TSH to get to goal would be kind of when it's a safe time to get pregnant. And that TSH should be stable for ideally at least a month before you proceed with pregnancy. And then if you were to need more extensive treatments with radioactive iodine, pregnancy is not recommended for 6 to 12 months post-radiation treatment. And this is basically because of the radiation exposure of birth defects. Additionally, a lot of patients also have the first month or 2 after their radioactive iodine treatment, they might skip a period. So the pregnancy rate actually decreases slightly just right after the radiation treatment. And it's just your body's way of responding to the radiation treatment. So if you do get the radioactive iodine, it's generally 6 to 12 months later. And 6 months is generally when we find out after if if you had a lobectomy that all the cancer is removed. So again, we want to go back to ideally you would have no evidence of disease because that's the best situation to be in, but not everybody can be in that situation. So that if you're not, again, it's just a conversation with your endocrinologist at that point. So then that brings us to the question about, will pregnancy make my thyroid cancer worse? From what we can tell in the literature, if you've already had an excellent response to treatment, so you currently have no evidence of the disease, then the answer is no. There is not a significantly increased risk that the cancer will recur or cancer will grow. Now, the issue is in patients who are biochemically incomplete or structurally incomplete. So biochemical incomplete response is basically you have an elevated thyroglobulin level, but we haven't been able to find where exactly that is coming from. And a structural incomplete response is basically you have some sort of lymph nodes or you had pulmonary metastatic disease. There is a small possibility that cancer can grow in those particular patients, but again, it's a balance and seeing how long your disease has been stable and what is your time frame of getting pregnant, where are you in your reproductive journey. So all of those things to be taken into consideration when deciding whether or not to proceed with pregnancy in the bottom two cases. And then the question that often comes up in my patients is that, how much thyroid hormone do I need in pregnancy? So thyroid hormone requirements increase by 25 to 50% during pregnancy. That's just because the thyroid gland gets larger. And so naturally, if you had a thyroid gland, it would make more thyroid hormone to help the baby in the first trimester and then kind of even itself out after that. So the majority is that you're going to need more thyroid hormone during the first trimester and then maybe start decreasing in the second and third trimester. What we currently recommend is to take 2 extra tablets at the time of diagnosis and then get monthly blood work, a TSH and total T4 about every 4 to 6 weeks, so once a month, at least for the first 2 trimesters. And during the third trimester, if you've been stable, you can decrease that to once during the third trimester. And then following after delivery, you would return to your pre-pregnancy dose and get blood work at 6 weeks after your delivery. We don't recommend preemptively starting extra thyroid hormone in anticipation for getting pregnant because sometimes people can get pregnant the next week or they can get pregnant 6 months down the line. And so we don't want to make patients hyperthyroid while preparing for pregnancy. So I usually tell my patients that, once you get a positive pregnancy test, remember to call us. We'll go over the instructions with you if you don't remember, but just basically either Wednesday, Sunday, Wednesday, Saturday, take an extra tablet on those 2 particular days. And then how is thyroid cancer monitoring during pregnancy? So if you had an excellent response to treatment, so you have no evidence of disease, there's no dedicated monitoring or current recommendations during pregnancy because the risk of the cancer recurrence is pretty small. And then you would just get a follow-up ultrasound after deliveries, anywhere between 6 weeks and 6 months after delivery. And for those patients who have a biochemical or structural incomplete response, we would get a thyroglobulin every trimester and a neck ultrasound at least in the second trimester to ensure that there's no growth in any sort of abnormal lymph nodes that you are monitoring. So what do I need to remember from today's talk? So the thyroid gland grows during pregnancy and nodules may form. Neck ultrasound and FNA biopsy are safe during pregnancy for the diagnosis of thyroid cancer. If needed, surgery is the recommended treatment for a newly diagnosed thyroid cancer during pregnancy, and it's recommended during the second trimester to decrease the risk of miscarriage or premature delivery if it's done in the third trimester. Radioactive iodine is absolutely contraindicated in pregnancy and breastfeeding. And then pregnancy after thyroid cancer is common, it's safe, what's recommended. So, it's important to remember that, yes, it's okay to get pregnant afterwards. And thyroid hormone, your dose increases in pregnancy, and they'll go back to being normal after you deliver. Okay, thank you. And I will hand it over to Dr. Nguyen. Or actually, do you want me to take, I can do the one question. I'll do the 2 questions and then I'll hand it over to Dr. Nguyen. I'll just read out the question. So if a patient with a pre-existing diagnosis of high risk PTC, and the goal TSH is suppressed. Yes, so a lot of times we do still increase the dose by 30% to accommodate for the demanding of pregnancy. But again, it depends on how symptomatic the patient, like how symptomatic you were. So if we were to increase the dose and you were getting heart racing or other symptoms, then I would decrease the dose, but yes, we still increase the dose. And I do follow a more suppressed TSH, but if for pregnancy, I think the second question was the first one.
We have a question in the room here too.
Yes. So if you have poorly differentiated thyroid cancer diagnosis, but no evidence of disease, this is a difficult question because this is an even smaller group of patients who have poorly differentiated thyroid cancer. We don't know if there's a significant increased risk of cancer during pregnancy, partly because having poorly differentiated thyroid cancer actually has an increased risk of recurrence. So we don't have any particular studies dedicated to that topic. That being said, if you have no evidence of disease, then I think most endocrinologists, if you wanted to get pregnant, would just monitor you very carefully. They would probably monitor you during pregnancy rather than in a patient who had like differentiated papillary thyroid cancer with no evidence of disease. So you just be monitored more frequently. What was the question in the room?
Oh, thank you. If I had a lobectomy done, if I were to get pregnant, I'm on suppressive therapy right now. Would I still need to double the dose upon knowledge of pregnancy, or talk to endocrine first?
You should definitely talk to your endocrinologist. Some endocrinologists choose to increase it by 1 tablet. Some endocrinologists choose to increase it by 2 tablets. But it also depends on like if you're having frequent miscarriages, if you are, how long it's taking you to get pregnant. And Dr. Nguyen will talk about some of these risks of the subclinical hyperthyroidism prior to pregnancy. But the baby would be monitored more carefully. OB would monitor the baby carefully. And if you were having any sort of fetal tachycardia, or if your total T4 was significantly higher, we might reduce the dose early on compared to if you were not on suppressive therapy.
Okay, thank you so much.
Mm-hmm.
All right, thank you so much. Thank you, Dr. Desai, for that. So we're going to shift a little bit now to fertility. This is a relatively more kind of recent topic that has kind of come into the discussion in the last several years. There's a growing body of data and literature and studies that are looking at this now. I'm part of the task force for the next thyroid and pregnancy guidelines, and I think we're going to have more emphasis on this topic in the next set of guidelines, so that should be helpful as well for both physicians and patients. So I'm going to talk a little bit about quality of life and pregnancy outcomes, and then touch on radioactive iodine and fertility, and then a little bit about breastfeeding, and then we'll kind of open it up to questions after that. So in terms of the effect of thyroid cancer and quality of life, there's been several studies that have demonstrated that there is perhaps a decreased quality of life in terms of measures when patients with a history of thyroid cancer have been polled compared to the general population. And this seems to be perhaps particularly true in young women patients. And it may be mediated by increased psychosocial distress related to pregnancy planning or kind of future planning for parenthood. So I think there's going to be a growing emphasis for physicians to play an active role in kind of providing information and support and having this be a bigger part of the conversation. So when we look at the impact of thyroid cancer on pregnancy, a lot of the data has been sub-analyses of large studies in patients with a history of cancer of different types. But in these sub-analyses, they have not found that the risk of adverse obstetric outcomes is higher in patients with thyroid cancer than in those without a diagnosis of cancer. This study published in Thyroid in 2019, evaluated over 7,000 patients with thyroid cancer and compared them to 2 million patients without thyroid cancer and monitored their offspring, and they were followed for 80 months. And the study looked at various adverse obstetric outcomes listed here, including C-sections, preterm delivery, preeclampsia, and then stillbirth. The study found no difference in adverse obstetric outcomes between those with a history of thyroid cancer and those with no history. This study by Spiegel in 2019 also looked at a large number of patients over 14. This is a retrospective study over 14 million patients, 580 of which had a diagnosis of thyroid cancer. And they also looked at neonatal outcomes and compared those with a history of thyroid cancer to those without cancer, and did not find any significant difference in outcomes. In regards to the data that we have for patients who are actually diagnosed during pregnancy, we don't have as much data here, but the available data that we do have does not indicate that there is a higher risk of adverse obstetric outcomes in these patients as well. So kind of now moving on to radioactive iodine and fertility. The questions that come up are, does radioactive iodine affect menstrual cycles? And the study was a large systematic review of over 22 studies that looked at the effect of radioactive iodine therapy on ovarian function and fertility in patients with thyroid cancer. And they found that in the first year after radioactive iodine, there was a prevalence of about 12 to 30% of menstrual irregularities in patients. And 8 to 16% of these patients experienced amenorrhea, which is kind of defined as an absence of menses for either 3 months in a patient who previously had regular cycles, or 6 months in somebody who had irregular cycles. Does it affect menopause? The answer seems to be yes, slightly. Again, when they did the retrospective study, they found that there was a median difference of about a couple of years between those who had received radioactive iodine compared to those who didn't. So 49.5 versus 51 years. So now the question of, does radioactive iodine affect fertility? In the last decade, there's been a greater focus on the role of anti-Müllerian hormone, also called AMH, and its role in fertility. It's secreted by granulosa cells of growing follicles in the ovary, and the levels may reflect the size of the growing follicle pool. It's not cycle dependent, and it gradually declines with age. So it's kind of considered a potential marker for kind of the growing follicle pool, and it's been shown to correlate between correlate with antral follicle counts. So a lot of studies have started looking at radioactive iodine and AMH levels. This is a meta-analysis, again by Peak et al., that evaluated 4 studies that had been done looking at kind of baseline AMH levels before radioactive iodine, and then follow-up levels at 1 year after treatment. They did find that the AMH level there was a mean difference of about 1.5 in those who were treated. And some of the data does seem to suggest that perhaps this might be greater in patients who are older, over 35 years old. And this kind of does make sense if we think about AMH declining with age already, even in patients who don't receive radioactive iodine. However, in young women with low AMH levels, fertility does not appear to be compromised. And even in women aged 30 to 44, there's no apparent relationship between low AMH and actual pregnancy rates that have been reported. AMH is used as a predictor of potential success when patients are undergoing assisted reproductive technology or ovarian stimulation as part of like an IVF process. So, you know, in terms of its actual role in fertility, I think there's a little bit, you know, still to be answered. So the conclusion of that systematic review of over 20 studies looking at this found that radioactive iodine was not associated with long-term infertility or neonatal mortality. I do want to focus on a recent paper that was just released this year in 2023. This paper looked at infertility and pregnancy rates in patients with thyroid cancer history. It's a retrospective study. They looked at over 1,000 patients and compared them to about 5,000 patients who did not have any history of thyroid cancer, and they followed them for 10 years. They looked at infertility rate in thyroid cancer. They did find a significant difference in those with a history of thyroid cancer of 24% compared to 20% in those without a history of thyroid cancer. This seemed to be more apparent in patients as they got older. For example, if you see here below the age of 27, it didn't seem to be significantly different. But then when you got over 27, the difference became larger. And then over 35, again, a little bit of a larger difference. However, the pregnancy rate was comparable in the whole cohort. So, 46.9 compared to 47.7, and this was true across all age quartiles. It is notable, however, that this study was done in a country that had universal health care and access, access to consultations for fertility. They also looked at time from the diagnosis to the first pregnancy. And they did find that it was statistically significant and longer, 37 months in those with a history of thyroid cancer compared to 31 months in those without. Then they looked at those who received radioactive iodine, and they found that this was even more significant, that those who were being treated with radioactive iodine, the median time to first pregnancy was 45 months compared to 29 months without. However, when they looked at rates of infertility and pregnancy, they didn't find a difference in those who were treated with multiple treatments of radioactive iodine compared to those who had not been treated with any radioactive iodine. So how long then should a patient wait before becoming pregnant after radioactive iodine? And Dr. Desai touched upon this. So in general, the current recommendations recommend a 6 to 12 month period of time. The optimal time clearly is not well established, but this is the range that's been provided by the two different guidelines that are currently out there by the ATA. Radioactive iodine in pregnancy is contraindicated, as Dr. Desai said, and this is because radioactive iodine can cross the placenta, and just how it would be acting on a patient's thyroid, it can act on the baby's thyroid gland and cause hypothyroidism. So it definitely should be deferred until after delivery. So is it okay to breastfeed if you've had a history of thyroid cancer? In regards to thyroid hormone medication, there is no problem, right? It is present in the breast milk, but it's really a tiny amount of the baby's, total daily thyroid hormone requirement. However, radioactive iodine does concentrate in breast milk, so that's why it's contraindicated in breastfeeding. If you're going to do a diagnostic study, the breast milk should really be discarded also for several days. This is a little bit shorter acting, and so it's not quite as long of a period that you would have to wait after radioactive iodine exposure from ablation and treatment. If it is needed, it's recommended to hold the breastfeeding for 6 weeks prior to the treatment and then 3 months after the treatment. And that's because a lactating breast is very efficient at concentrating iodine, and we want to reduce the exposure to the breast and contamination with radioactive iodine. So with that, it's very important to kind of talk with your physician regarding your plans for pregnancy, to review these topics, and especially how they kind of relate to you and your personal timeline. So in summary, quality of life may be decreased in patients with thyroid cancer due to psychosocial distress related to pregnancy planning. The majority of data shows no difference in risk of adverse obstetric or neonatal outcomes in patients with a history of thyroid cancer. Menstrual irregularities do occur in up to 30% of patients in the first year after radioactive iodine. And radioactive iodine is associated with a slightly earlier menopause. AMH levels are decreased at 1 year after radioactive iodine, and this effect may be greater in patients who are over 35 years old. Infertility rates may be higher slightly in patients with thyroid cancer, again, associated with increasing age. However, comparable pregnancy rates in patients with thyroid cancer, including those who've received multiple doses of radioactive iodine. But it's notable that the time to pregnancy in patients is longer in patients who have a history of thyroid cancer, and especially if they're receiving radioactive iodine. Again, avoidance of pregnancy after radioactive iodine treatment for 6 to 12 months, and avoidance of breastfeeding after any radioactive iodine treatment for at least 3 months. And then just kind of an emphasis to have a greater discussion with your physician. And with that, that's the end of my talk. Thank you so much.
Okay, we have a few questions in the room.
Let me figure
Question on the length to get pregnant post-thyroid cancer. Why do you think it's longer in women or men who have had thyroid cancer? Is that due to the lack of the thyroid, or?
I think it's partly due to everything that happens after a diagnosis. Just the duration of from the time that you find out of the diagnosis to the time that you're getting treated, to the surgery, to optimizing your thyroid hormone levels after, or if now you're getting radioactive iodine and now you have to wait 6 to 12 months. All of that, I think, contributes to this increased time that we see.
Okay, so it's not as like hormonal, it's more just you're going through all this stuff, therefore it's taking longer.
Yes, I think it's a lot of that. However, those menstrual cycles are affected, right? So if we know those menstrual cycles are being affected in a certain percentage of the patients, not everybody, but if that's happening, or thyroid levels are fluctuating, then definitely menstrual cycles can become irregular. And if they're irregular, then you may not be ovulating. That can also lead to an extension, like a longer period before you might be able to become pregnant.
Thank you.
You're welcome. Sorry, I'm trying to figure out how to stop my slides.
Hi, the question is, well, you mentioned, I have two questions. One, because you mentioned about the menstrual cycles being affected. So I'm not actively trying to get pregnant, but soon hope to be, but the menstrual cycles did become irregular. So is there an estimated time frame of when it goes back to what it was prior to the diagnosis? That was the first question.
So different studies have kind of different numbers. That that huge systematic review kind of just looked at what happened at 1 year. The studies that I've looked at, they do talk about kind of a recovery, maybe around anywhere from 6 months to 10 months and plus have been quoted. So the data is a little bit all over the place. And I think the reason for that is it kind of also probably is affected by the patient's menstrual history prior, like if they were very regular or not, or their age as well at this point in time. So I think there's a few different factors at play, but the majority of the papers do talk about a recovery and kind of a return back
Okay.
to regularity.
Thank you. And then the other one was, you said on the last bullet point on your last slide to speak with your physician. Of course, if you have history of thyroid cancer, you have a physician who's an endocrinologist and you'll have an OBGYN. I'm lucky that both of them are on the same Epic and MyChart system, but how do they, in addition to communicating online, how do I have those conversations to ensure that they're on the same page and,
Yeah.
I don't know, have the same values or have the same plan?
Right. Yeah. And I think, it's, I think we're trying to definitely get physicians to talk about this more and talk about it early, definitely within the endocrinology group, but then also with OB. So from a patient, point of view, then I think you can share your plans with both physicians and kind of request that, notes are being shared between the two and a discussion's being kind of had amongst your whole team. I think especially like if it's very pertinent at the beginning of a diagnosis, perhaps, or, and maybe timeline's really important for you to talk, and figure out what your goals are and what you would like. Then I think that discussion kind of has to be had. And I think usually now physicians are better about sharing notes, especially if you're in one system, but I do understand how hard it is, like, to sometimes kind of have that happen when physicians are at different systems. But I think if you just express that with your doctors, then they'll definitely do what they can to talk to each other so that everyone's on the same page with your plan and what you want.
Looks like we have several questions in the chat. Are you able to see those, Dr. Nguyen?
I'm sorry, I can't figure out how to.
I'll read them out to you, and then most of them are
funny.
directed towards you anyway. So the first question was, I had a total thyroidectomy and radioactive iodine, both done earlier this year. I am currently dating and hoping to marry and have kids. I would like to know if there will be any issues conceiving in the future and if my eggs will be less viable. And then if there's any resources to help with psychologic improvement.
Yeah. So, from the data that we have currently, all right, it does seem like, yes, if your diagnosis was just this prior year, that in this coming year, your menstrual cycles might be irregular. If I don't know if you had to, I can't remember if you said you got radioactive iodine, so that's another time thing. But the overall data does seem to suggest that the pregnancy rates are pretty comparable for patients with if they've had thyroid cancer or not. So that's, to me, is pretty hopeful. Like when I see that data. So even though some fertility kind of issues might be happening in this first year, like these AMH levels and whatnot, we still don't have great data to show AMH levels and pregnancy rate correlation, right? So I think that it's definitely something to talk about with your doctor, your endocrine, your OB, see if you're having regular cycles or not, if you're ovulating, right? And then I think overall, the biggest factor for fertility is always age, like given everything, right? It's age. So I think that's where it becomes a more important topic for physicians to kind of acknowledge that and bring this up as a topic. And so for you, I think, just emphasizing that with your doctors. In terms of resources, I think the American Thyroid Association may have some resources out there. I think the guidelines that are going to be coming out, but I don't think it'll be probably for another year or so. We're hoping will also be a resource for patients and doctors as well. And then support groups that I am not as positive or sure about if there are. I think there should be out there, but I don't know of any like kind of formalized or large kind of support groups. But I think within certain within each community, there likely is, and maybe even online, there likely is. Yeah.
Can you elaborate, Dr. Nguyen, on how REI can affect a woman's menstrual cycle?
REI and menstrual cycle. Oh, so in the data, what it's really kind of shown is more irregularity. So that could be anything from duration of your cycle, missing cycles, shorter cycles, that kind of has been described. Only a portion of those patients actually had full cessation of cycles, meaning no more cycles. That was only kind of, a smaller percentage of those patients. But generally, it's those kind of changes that would happen.
Thank you. I know we didn't discuss this, either you or I, but is it harder if your pregnancy to get pregnant if your TSH is suppressed versus subclinical versus low normal thyroid TSH?
Yeah, so this is a very interesting topic. And I kind of just looked into this pretty recently, and there's very little data on subclinical hyperthyroidism, which is what the majority of patients who have a history of thyroid cancer and are being suppressed with thyroid hormone are going to fall into that category. In terms of outcomes in pregnancy, right now, we generally feel like there's no increased risk of being subclinical hyper in pregnancy itself. And that's why, as Dr. Desai said, patients can stay at the same degree of TSH suppression in their pregnancy as they were before, and it's considered safe for mom and for baby. In terms of fertility, there's really not a lot of data. And especially looking at data for fertility, subfertility, or patients undergoing assisted reproductive technology or ART, IVF, there is not a lot of data at all. I think much of the data talks about menstrual irregularity in subclinical hyper or overt hyperthyroidism, which generally kind of improves as you treat that. And that's kind of more for innate too, not necessarily for iatrogenic. So what that means is the data is more for patients who have that, like, who just have those conditions kind of for other reasons, not necessarily for patients who are being treated with thyroid hormone purposely to suppress them. We just don't have a lot of data in that area. In terms of how I counsel patients going towards this, it depends. Sometimes I will see like their degree of suppression, like, do they really need to be that suppressed? It's not uncommon that I encounter patients who have been suppressed for a very long time, and it may not even be warranted anymore. And so in those patients, I might consider easing up on their TSH suppression. However, if you need the TSH suppression for your thyroid cancer, then we keep it suppressed and they proceed going forward with their plans for pregnancy. And if they need to do any sort of fertility or ART, we keep them at that same level. And as of now, we don't have data to suggest that it makes a difference.
Thank you. I will let you do the next one and then I'll do the one after that. Sorry. All of these are directed.
And then when you guys are done, we have a few more questions in the room too.
Sure. So Dr. Nguyen, how does PCOS affect fertility without radioactive iodine or with radioactive iodine? And I guess the patient's 42. So does that make an impact?
Yeah, so PCOS, like kind of independently, right, is another factor for fertility and pregnancy in itself. So I kind of am remembering maybe one paper that actually kind of looked at this, or like AMH and PCOS, but I don't remember the details offhand. But I would say overall, that in itself kind of makes it more challenging. Age is probably the biggest factor of them all. So, 42, yes, we know after 36, kind of ovarian reserve starts to drop. So, I think if you are interested in pregnancy, you would want to have a discussion sooner than later about it and talk with your endocrine and probably your OB too. We do have a lot of technology now available, like in terms of assisted reproductive technology. However, it is quite costly and often not accessible to the majority of patients. But there can definitely be a conversation that you can have with your endocrine about different options and considerations for both the PCOS and kind of the history of the thyroid cancer and the radioactive iodine.
Okay, I'll get the next one. So there was a comment that 6 to 12 months, waiting 6 to 12 months after radioactive iodine is a pretty big range. The reason that it's a little bit different, we don't have a significant amount of data on whether 6 months versus 12 months makes a huge difference. But also, I usually recommend a year, but age will factor into this as well, as Dr. Nguyen was saying. So if you're younger, if you're like 21 years old, I'd probably say just wait the year just to make sure everything's clear. If you're a little bit older, I might recommend closer to the 6 months. The other issue is that we want to make sure that your cancer is as cured as possible before you proceed, or if it's not, that we understand what the rate of growth is. So that actually takes time to present itself, to kind of explain how that's going to work. So generally after radioactive iodine, it takes 6 months to work anyway. And sometimes it can take 12 months to work. But when we're evaluating that, we get the ultrasound at the 6 month, we get the ultrasound at the 12 month. So sometimes your endocrinologist may just recommend for you to wait until we get that ultrasound so that we can safely tell you that, your chances of the cancer recurring during pregnancy are very less and the monitoring is less, as opposed to if we didn't have that information initially. I don't know, Dr. Nguyen, do you recommend the 6 months or 12 months? Or many factors probably go into that.
Yeah, I think it's kind of interesting because clearly here it just shows the lack of data that we have, right? Like one guideline will say 6 months, and then the other guideline, it says 6 to 12 months, and it just reflects that we don't have great data for this. So I kind of use the approach you do, doctors, like weighing in other factors. Yeah. And if you have the luxury of that time or not.
All right, we'll take some questions in the room.
Oh, yeah. Okay. We
Okay.
have one more online. Do you want me to just cover the last one online and then we can go straight?
Yeah,
to
sure.
Okay. The last question was, what is the birth control recommendations for RAI? Generally, some endocrinologists might recommend 2 forms of birth control, but you should have at least one solid, good form of birth control. So this can be OCPs. It can be any of the implantable devices. Dr. Nguyen, do you have a specific recommendation?
I don't.
One or two?
You just want to be super careful, right? So get some form that's effective that is working for you. If you're doing OCPs, but you may not be the perfect, patient with that, taking it regularly, then this is a time when you want to be very careful. You just, so 2 methods could be a great idea too. Phexxi is, I think, a non-hormonal, like gel type, and I just don't know enough to comment on like its effectiveness versus a different type of OCP effectiveness. But perhaps the OBs might be better at commenting on one form versus like another in terms of effectiveness. And again, it probably depends on you too as the user. Yeah.
Dr. Nguyen, my question is, if you're going through suppressive therapy and you're considering freezing eggs, I think you touched on this in a previous question, but is there anything to be aware of or cautious of there?
Yeah, so usually if you are kind of in an early part and your suppressive therapy is considered, needed and that's the plan for you, then typically I don't change that going into kind of ovarian egg freezing and the steps for that. So usually we say proceed ahead and just continue your meds. Now, after you do kind of the ovarian stimulation, we do know that it affects your thyroid hormone levels. So TSH will definitely kind of potentially get altered by the different hormones that you're being given during the ovarian freezing. And those are felt to be transient or temporary. So in general, we kind of just let them correct, let it kind of follow you closely after, but it is a period of time where you would be wanting to work closely with both your REI and your endocrine and let your endocrine know what you're planning on doing so that they can monitor your levels after and make sure that the dose doesn't need to be adjusted afterwards.
Okay, awesome. And so would it affect the number of eggs or anything like that, you
Again,
think?
like we
Or
don't have great data.
yeah.
So we don't, I mean, maybe we will going forward, but right
Yeah.
now we don't have a lot of data on this. So we're kind of gathering it. And the data that I could find is really looking at more, yes, they kind of group subclinical and hyper all together. And they kind of looked at fertility and ART. There's just not enough data, I think, to tell you for sure that there's, one way or the other.
Okay.
So, and with that, it doesn't appear that we have data that shows that it's necessarily affecting outcomes, but, I think without more information, right now we're left like kind of just having to make decisions. And so that's kind of my personal approach, is where I look at the patient to see like, okay, if they can be, their TSH suppression can be kind of more normalized, maybe I might consider that. But if their thyroid cancer warrants suppression, I don't mess with that. But the key is to keep you at subclinical, right? Because some patients, sometimes they become overtly hyper with their suppression, and you don't want that. You want it to be managed at subclinical. Yeah.
When you say subclinical, what does that mean?
Typically what that means is your TSH can be low, but then you want to try to keep your thyroxine levels within a normal range or upper limit of normal, like you want to kind of try to avoid like super high levels. I do understand that this can get complicated though, because labs sometimes get affected by having no thyroid and being on thyroid hormone medication. So I think, just working with your endocrinologist to just keep it at the appropriate level and not maybe give too much would be
Thank you.
Mhm.
Hi, one more question in the room. My understanding is that it's not safe for pregnant women to take T3. And so for myself, my endocrinologist and I were not able to get my TSH within target range, taking T4 alone. And so just curious, like if you see this in your patients and you recommend that they stop taking T3 a certain timeline before they know they're trying to conceive, to see if they can get their TSH at a good stable range like before.
Yeah. So this kind of comes up quite a bit. I will say that in thyroid cancer in general, the recommendation is levothyroxine for suppressive therapy. And if the reason that T3 isn't recommended in pregnancy itself is because it does not cross the fetal blood-brain barrier. So while you're getting T3 and your levels look good, baby is not, right? And then oftentimes when you're on T3, your T4 levels are lower too, right? So then there's this concern that baby's not getting enough thyroid hormone. And in the beginning of pregnancy, baby is relying completely on mom for thyroid hormone. And if mom's taking thyroid hormone, relying on the medication that mom's taking. So if you're considering pregnancy and you're on T3, I do generally work with my patients in the preconception period to switch them over to levothyroxine or T4 alone. The levels are hard because when you're titrating to levels, again, the free T3 assay is not great. And sometimes, so if you are going to check an assay, I would say total T3 is probably better than the free T3 assay, which can be kind of low and run low. But we often do target for TSH goals, really. And when we're talking about optimizing patients for pregnancy or, or patients with thyroid cancer, all of it's based on that TSH goal. I would try to switch over. I would keep working on the levothyroxine dose in the preconception period to kind of prepare for the pregnancy. Yeah.
Hi, since there's already a small subset of, we're a small subset. It's only applicable to women who are of fertility age who plan to conceive. Since there's very little data or no data at all for, IVF or planning to conceive, how are we able to get access to if there will be a new study or how to participate? Like, in some of the other sessions, there was a database that people are entered into, or, is there
At this
detail?
point, I don't personally know about, what all the different studies that might be going on. I'm hoping and hoping that there is more studies looking into this. And I think, in terms of the national associations, that would probably be a good place to start to see if there's any work here. There's also a list of like RCTs that are happening everywhere. And I guess searching through there could be an option too. Yeah, but I do appreciate, I think that would be great if you want to participate in. I just don't know exactly the resources myself to how to get you involved in that right now.
I think we're all set in the room. Are there any more on Zoom?
There was one other question on Zoom. Somebody had written she's 34 years old, 7 weeks pregnant, waited 18 months after our radioactive iodine. Endo has not increased suppressed TSH yet. I'm assuming that maybe that's the endocrinologist has not recommended an increase in thyroid hormone replacement. Is there a higher risk of miscarriage or other issues? And then is there an ideal frame to start and stop adjusting the TSH?
Do you want me to take this one?
Sure, you can take that one.
So, yeah, the general thinking is that you do need more in pregnancy. And so often we will tell our patients to kind of increase their dose. However, if your endocrine perhaps already did a lab test for you, maybe, and saw that the lab looked fine, then they might have made that choice not to increase it for you. I don't know exactly what your endocrine's thinking. And then typically you monitor pretty closely. So you'll be checking the lab again, usually it's every 4 weeks until mid-gestation at least, and then you can spread it out after that. So in terms of times for adjustment that you asked, that's 20 weeks would be the point where you could then start to reduce the frequency of checking after. Prior to that, your dose can change quite a bit before 20 weeks. So hopefully you'll have another lab check coming up soon, or your lab test was already at goal, and that's why your endocrine may have decided to do that.
Okay, I think we're at time, and I think we covered all the questions. So thank you both. This has been a great presentation.
Great.
Thank you.
Thank you everyone for joining.
Thank you.